Hi, everyone, and welcome back to the Caregiver Empowerment Program. Today, we'll be focusing on an introduction to borderline personality disorder. My name is Alexandra Ferreira, and I'm a senior clinical psychologist at NUA Healthcare. In today's webinar, an introduction to borderline personality disorder, also known as BPD, we'll be providing helpful information in relation to this mental illness. This webinar has been divided into two different parts. Part 1, an introduction to BPD, and Part 2, an introduction to BPD, how can you help? In Part 1 of this webinar, we'll be providing helpful information in relation to personality disorders whilst focusing specifically on BPD. We will also talk about the role of childhood and adolescence experiences, including trauma and attachment difficulties, that have been found to strongly impact on the development of maladaptive responses resulting from cognitive, emotional, and interpersonal difficulties. In Part 2 of this webinar, we'll be discussing evidence-based assessment and intervention procedures currently used in clinical practice to support in managing the difficulties and the risks associated to BPD, as well as to prevent long-term implications. We will also have available for download additional resources, suggestions of helpful books, and information on relevant support groups, as well as guidance on where to seek additional support. These webinars are suitable for supporting individuals who have a diagnosis of borderline personality disorder. Over the course of this webinar, in Part 1, we'll be covering a series of topics, and these include what do we mean when we talk about personality, what it looks like to have a personality disorder, what does BPD look like, how having BPD impacts on a person's life and those they care for, the role of traumatic life experiences, how someone's relationships throughout their life influences their personality, and how to know if someone has BPD. We'll then complete this part with a summary of all the content discussed before moving on to Part 2. So what do we mean when we talk about personality? Personality can be identified as a set of individual characteristics that differentiates us from other people and that are stable over time. These individual differences, which are called personality traits, are often found in patterns of thinking, feeling, and behaving, and they differ from person to person. These traits are evident in a wide range of social and personal contexts and situations. Personality traits do not include physical characteristics, abilities, or temporary states of being. We all have personality traits, and some are more positive than others. So essentially, our personality is constituted by a series of personality traits, some more positive than others, and that is applicable to all of us. And these influence the way that we think, the way that we feel, and the way that we behave across a series of situations, and they're quite stable over time. Next, we're going to look at a slide of examples of personality traits to get an idea of what these actually look like and what we're referring to when we talk about personality traits. Over here, we have a list, and these are just a few examples, such as optimism, creative, open-minded, curious, happy, calm, easily angered, anxious, talkative, agreeable, organized, outgoing, and the list goes on and on. But I'm sure you've met a person who you would describe as extremely talkative, sociable, and outgoing, and that happens across multiple settings in their professional life, in their personal life, etc. So it's safe to say that that person is a sociable person, is a talkative person. Whereas on the other hand, we may have encountered individuals who might have a greater tendency to feel anxious about situations. And it's not that they have an anxiety disorder or that they can't cope with their anxiety, but we notice that their predisposition when facing situations is that there is some anxiety and reluctance to engage in the unknown. So we all have certain predispositions that are influenced by our personality traits, and these affect the way we think, feel, and behave with ourselves as well as with other people. What does personality disorder look like? When personality traits, like the ones that we just saw, become inflexible and maladaptive and cause significant functional impairment or subjective distress, they constitute as a personality disorder. A personality disorder is a lasting pattern of thoughts, emotions, and behavioral experiences that is significantly different from what is expected from the individual from a social and cultural perspective. This pattern has an onset in adolescence or early adulthood and is persistent and stable over time. Personality disorders manifest in two or more areas of functioning. So they affect and manifest in the way that we think, our thoughts. So the way that we perceive ourselves, others, events, the world. They affect our emotions, the range of our emotions, the intensity of our emotions, the changeability or how rapidly our emotions may change, as well as the appropriateness of our emotions in relation to a specific situation. They affect our relationships or may affect our relationships, whereby they may impact on the way that we relate with others and behave in relation to other people. And finally, we have impulse control, which is another behavioral component, which is they may affect one's ability to resist temptation and urges. These are the areas that we typically see affected in individuals that have personality disorder, and we will look at these more in depth when we discuss them in the context of BPD and how they manifest in an individual that is diagnosed with borderline personality disorder. We'll be referring to general overview of what it looks like because people with BPD may differentiate and may differ in the way that they present, even if it is in relation to their own specific personality traits or their own specific learned coping strategies. Here are a few examples of some personality traits that might not be as adaptive or might not be as positive as the ones referred a few minutes ago, and that if they are inflexible, if they are not allowing for the person to adjust to situations, if they are causing distress or if they're impairing in the person's functioning, then we might consider them to be traits that might be impacting and also resulting in the development of a personality disorder. So some would include being self-centered, perfectionist, aloof, suspicious, unstable mood, emotionless, careless, somber, self-destructive, rebellious, deceitful, overcautious. Again, these are traits, these are personality traits. And I'm sure that when you look at the screen, you might identify one or two that you have yourself. That doesn't mean that you have a personality disorder, because as I mentioned earlier, we have both good and less positive personality traits that make who we are. And that is perfectly normal. However, we can see, for example, that if someone has perfectionist tendencies and they feel that they need to meet very high standards in everything that they do, that this person might be more predisposed to experiencing anxiety and depression and other mental illnesses or mental health difficulties if this trait is not manageable. However, when we think about a personality disorder, there are multiple traits that are just maladaptive, quite fixed, and then rigid, in that we're not really able to change them, and whereby they impact significantly in the person's day-to-day functioning or emotional well-being. So one trait alone does not mean that the person has a personality disorder. They just have the specific trait due to previous experiences in their life. So in personality disorders, we have them grouped up into three clusters based on descriptive similarities. We have cluster A, which is described as odd or eccentric. We have cluster B, which is described as dramatic, emotional, or erratic. And we have cluster C, which is described as anxious or fearful. Main characteristics of personality disorders grouped in cluster B. The reason we're focusing on cluster B is because BPD is in cluster B. So the main characteristics that we might see in BPD, as well as the other personality disorders that form this cluster, which are antisocial, histrionic, and narcissistic personality disorder, may be dramatic presentation, emotionality, erratic behavior, impulsiveness, reduced ability to have empathy, unstable emotions, and relationships. So we will see these characteristics, or some of them, across these 4 different personality disorders. But once again, today we're focusing on BPD, and moving forward, that is what we're going to be talking about. So what does BPD look like? Borderline personality disorder is a serious mental health disorder characterized by persistent dysfunction and instability in patterns within several domains: mental or cognitive, emotional, behavioral, and interpersonal. And we'll see what this looks like in more depth in the next slides. This mental health disorder affects mainly females with a percentage of 75%, and BPD affects 1 to 2% of the general population. So, how BPD comes across from a cognitive or mental perspective. People with BPD may display some of the following thought patterns. We may see in them an unstable sense of self. That is a persistent instability in the individual's sense of identity, and usually results in individuals with BPD to mirror those around them to a greater or lesser degree, depending on the severity of symptoms. So, when we're talking about this sense of self, the individual's thoughts about themselves can change very quickly depending on how they're feeling or what's happening in their surroundings. And we may see people with BPD mirror, or in other words, copy or do the same as people around them as a way to integrate themselves, because their sense of self is not stable. It changes and it fluctuates. And sometimes they do not know how to interact in certain situations or how to navigate them. We also see short-lived stress-related paranoid thoughts in some individuals with BPD. This is when there is continuous exposure to high levels of stress that can result in a person with BPD to feel paranoid and suspicious of others' intentions and plans. This typically happens if a person with BPD is exposed to a prolonged period of emotional distress or stress, where they're quite heightened in their emotional experience. Their feelings, once, as mentioned earlier, can be felt in a more intense manner when compared to people without BPD. And if experiencing this prolonged emotional distress, they may exhibit what we call paranoid thoughts, or what we also may refer to as pseudo-psychotic symptoms, and that they are paranoid and suspicious of other people. This has a lot to do with attachment difficulties and trauma experiences that are manifesting at a time that an individual cannot regulate their emotions. But we'll talk about that more in depth in the next slides. The next one that we have from a cognitive or mental perspective is dissociation. So this consists in an emotional detachment, which can be mild to severe, from one's immediate surroundings, including physical and emotional experiences, especially when these cause significant distress. So in other words, dissociation was a person just kind of switches off and blocks off from their internal experiences because they're too intense, too painful, and too distressing to manage. The individual does not have the coping resources to manage this distress. So what has happened is, over the years, the individual has, in a very subconscious manner, developed a coping strategy to block these things off when they become too overwhelming and the person is unable to cope with them. How BPD comes across from an emotional perspective. So people with BPD may display some of the following emotional patterns: intense anger. People with BPD may experience inappropriate, intense, or difficulty controlling anger. Quite often, we refer to people with BPD having what we call anger outbursts, in that they have an intense emotional reaction, which is anger, to a situation where that anger might not be proportionate, it may be too intense, and the individual struggles to bring themselves back from the emotion and to regulate it. Also, it is not proportionate to the situation, whereby we wouldn't expect a person to respond with that level of anger to that situation. This is something that we may see in individuals with BPD. However, they can also experience other emotions very intensely as well. But this is what we see from an external perspective. What manifests most prominently is the anger. They may experience chronic feelings of emptiness, so a feeling that is described as having a void inside. They also may experience mood swings, so they may be observed to have rapid and intense mood changes in response to situations. This is what we call reactive emotionality, that can last for hours or sometimes rarely for a few days. So, this means in relation to a specific situation that might be taking place, the individual may have a very intense response, a response that we would not expect for most people to have. And that response might take the individual a few hours to come back from, or on rare occasions, few days to come back from, because it impacts on them significantly, and they do not have, again, the tools or resources to manage those emotional experiences. So, in other words, individuals with BPD have their specific triggers, and those triggers can instigate a quick and rapid change in their mood that we might find unpredictable or unexpected. And the intensity of it is very, very high, making it difficult for the person to come back down within a few minutes. How BPD comes across from a behavioral perspective. So, people with BPD may display some of the following behavioral patterns: impulsivity. So, we may often see in BPD the spontaneous and rash decision to engage in certain behaviors or activities that may be potentially damaging to the individual or risky for others as well. These may include reckless driving, engaging in risky sexual behaviors, binge eating, substance misuse, etc. The individual typically tends to engage in impulsive behaviors, and what we've seen in research is that this is usually in response to very intense emotional states. So sometimes the need to engage in a behavior, the urge, and the inability to control that urge results from the person being emotionally dysregulated and needing to do something to manage that emotion. And sometimes they manage it by engaging in behaviors that can be dangerous or reckless for themselves and others. Another behavior that we often see in individuals with BPD, also when experiencing emotion dysregulation, is self harm and suicidal behaviors. This may include the presence of recurrent gestures or threats or behaviors of self harm and suicidal ideation. Again, this occurs when the person is highly dysregulated. On some occasions, people engage in self harming behaviors as a form to self regulate. As mentioned, there is a lot of emotional pain that the individuals experience. And on occasion, we find individuals who might engage in self harming behaviors to refocus their attention on a different source of pain as opposed to the internal pain, which is perceived as unmanageable. We also see people engaging in self harming behaviors as a form to, at times, elicit support and care from other people, because they do not have the ways and the means to communicate their distress, as it is so overwhelming, and they do not have the tools to cope with it either. And then, as well, unfortunately, we'll have the situations in which the individual cannot cope with the emotional distress, and there is a sense of hopelessness and helplessness that might result in their desire to end their life. How BPD comes from an interpersonal perspective. So, people with BPD may display some of the following interpersonal patterns as issues in their relationships. Now, this is most likely the area where you're going to be able to identify some of these experiences, because People that have a relationship with someone with BPD, regardless of the nature of the relationship, will experience some of the difficulties I'm about to go through. A lot of the difficulties experienced in BPD impact on the interpersonal relationships that they have with others. So, if you are interacting with someone with BPD, it is likely that you've experienced some of these, and hopefully, this information can provide you with a bit of context as to why it happens. So, one of the core features of BPD, and I'd say one of the major underpinnings of what we see in people with BPD, is a frantic effort to avoid real or imagined abandonment or rejection. And this has to do with usually previous experiences in life, which we'll touch on in a bit. But people with BPD may avoid abandonment by avoiding relationships altogether, by remaining in abusive relationships, or being more vulnerable to sexual coercion to maintain a relationship, etc. So people with BPD often engage in relationships, and the relationships are not always or do not always include the most healthy interactions. What that means is that the relationships are quite unstable, and usually this is always or almost always associated to a person being fearful of being rejected or abandoned. This can result from the fact that they may have been abandoned before and they want to prevent that from happening. So some people might opt to just not engage with people at all or have a very superficial interaction and relationship with individuals to avoid this possibility of being rejected and abandoned, by not giving people the opportunity to do it. Or people with BPD may be very fearful of being rejected, feel that they are not worthy, and therefore subject themselves to situations in relationships where they're being exploited or abused, or taken advantage of, because their fear is of being alone and they do not want to be rejected. So they will subject themselves to unhealthy interactions, dynamics, and even further trauma sometimes in order to prevent this abandonment and this rejection. So there is this fear of being alone, and being able to manage and cope with things by themselves. But equally, there is this fear that they are not lovable, and that has a lot to do with their previous experiences as well in the context of trauma and attachment difficulties. And we also see unstable and intense interpersonal relationships. So, individuals with BPD often alternate between extremes of idealization and devaluation of others. In other words, they can go from feeling appreciation, admiration, and care toward a person to all of a sudden feeling anger, depreciation, even hatred within a short period of time, and vice versa. So there's this fluctuation in moods, which you referred to before, but this fluctuation is not only in relation to moods, it's in relation to the way that they might perceive an individual. As I mentioned, abandonment is at the core of BPD, in that it influences how the person perceives others and themselves, and it contributes a lot to the person's interpersonal conflicts and fears. So, it is not uncommon for people with BPD who have gone through experiences of rejection and abandonment to actually perceive certain social cues, certain interactions, certain gestures as that means that that person is going to abandon me or reject me or disapproves of me, when in reality, those gestures, those situations, those interactions are neutral or do not mean any of that. So, what I mean is that people with BPD can maybe distort reality, and this is, in a way, a form of protecting themselves from, again, this fear of being rejected or abandoned. So oftentimes they might see things in people that might suggest to them that that person is going to walk out on their lives, and they will interact and they will respond to that. They will have an emotional response to that, even if the person did not intend that with whatever interaction, verbal or gesture that they engaged in. So they're very sensitive to this topic, and they The way that they perceive, again, one of the main things that is influenced in BPD as well as personality disorders in general is perception. Their perception of others can be distorted and biased due to this fear. So let's see how this manifests in a more practical manner. Let's take Mary's case. Mary is a young woman with BPD. She's in a relationship with John. She feels afraid that John might leave her for another woman or reject her because he no longer cares for her. Mary focuses a lot of her energy and attention on John, going above and beyond to make him happy so he does not leave her. John becomes busier at work and has less time for Mary. She may have difficulties in understanding this and perceive this as rejection or think that John no longer cares for her. Mary starts feeling anger toward John because she feels he is abandoning her. Mary engages in self-sabotaging behaviors by fighting with John and spending less time with him. Mary engages in alcohol abuse due to her inability to cope with the feeling of being rejected. Mary feels depressed, detached, and guilty for how she has acted. She understands that John's persistent support, that he was just busy with work and that he still cares for her. Mary focuses all of her energy and attention on John. So we see here that the fear of abandonment is at the core of Mary's behaviors and the way that she interacts with John. We see her wanting to please John and out of fear of him leaving. We see her misinterpreting a situation where John becomes busier at work, is unable to give her the attention and the time that he maybe could before, and that this is perceived as a sign of rejection. So here comes in the distortion, the misunderstanding of the situation, and again, the fear, the core fear of BPD, fear of rejection and abandonment coming in order to interpret and understand what is happening from Mary's perspective, but it is not accurate. Then we see the intense feeling of anger emerge in relation to the situation. We see impulsive and self-sabotaging behaviors due to a lack of ability to cope with the emotions that are emerging and the fear of being rejected. So Mary does not have coping strategies that are effective to manage the situation. And then after that, we see that there are feelings of guilt once she has stopped, reflected, and gone over the impulsive behaviors that she engaged in. But she wasn't able to prevent the engagement of her engagement in her urges and temptations. It was an impulsive act when she engaged in those self-sabotaging behaviors and alcohol consumption. And as a result now, she feels guilt. This would be a common cycle observed in someone that has BPD. So individuals with BPD are triggered in their relationships with others. The fear of abandonment and rejection is the most prominent feature of BPD. There is this hypersensitivity to threats of abandonment and rejection. A series of behavioral patterns occur in order to avoid being rejected by the other person. Sometimes this involves the need to reject the person before the person with BPD is rejected. We saw that in the case with Mary when she started to fight and argue with John and spend less time with him. She herself took it upon herself to push him away or pull herself away from him out of fear that he would be rejecting her and abandoning her. And this would fall in line with what we commonly see, which is pushing away the person before they have the opportunity to do that to us. We see intense emotional pain and dysregulation, impulsive and reckless behaviors in an attempt to regulate those emotions, but are ineffective in essence. Feelings of emptiness, guilt, and emotional detachment. And regardless of the outcome for the relationship, the cycle is reinforced as the behaviors are seen as protective mechanisms for the individual. So essentially, these behaviors will maintain until Mary learns new behaviors, until Mary acquires new coping strategies, new ways of thinking about this, new ways of perceiving how it is normal for her partner to maybe become busy at times due to other areas in his life that might be more active. And it is important for her to understand that misinterpretation of situations are what is in this case and are generally what lead to emotional dysregulation. So this cycle will continue because when Mary was pushing John away, it made her feel safer. And also when she engaged in alcohol consumption, that numbed out her pain, at least temporarily. So these were things that made her feel safe at the time. And if a person with BPD perceives that the behaviors that they're engaging in make them feel safe and protected, they will continue to resort to them, even if in the long run they only maintain this BPD cycle. So, how does having BPD impact on on the individual's life and those they care for? The impacts of BPD will vary depending on the severity of symptoms and whether or not the person has other mental health conditions, as these can aggravate BPD symptoms. However, in general terms, BPD can be extremely debilitating and impact a wide range of domains of a person's life, especially due to significant or recurrent periods of emotion dysregulation. These may include occupational functioning. As an example, the person is less likely and able to manage tasks of self-care and house management when emotionally dysregulated, may engage in neglectful practices toward physical, mental well-being, etc. From an interpersonal functioning perspective, the person may have poor trusting relationships with others, unstable relationships, inflexible interactions with others, feeling the need to please others, increased feelings of isolation, feeling the need to push others away, etc. So, from a social network perspective, there might be a lot of limitations with regards to the person's social support due to the way that they interact from a behavioral and interpersonal perspective. From an educational and professional performance perspective, the person may be affected as their job performance may deteriorate, and they may not have the ability to fit in with colleagues and or co-workers. They may have upsetting work-related experiences that result in emotion dysregulation, difficult professional relationships, etc. And ultimately, this may impact on the person's ability to maintain a job. And from a quality of life perspective, we see frequent episodes of intense emotional pain, feelings of emptiness, detachment from others and reality, loneliness and hopelessness, lack of sense of direction in different areas of life, more likely to develop other mental health conditions such as anxiety and mood disorders. And also, we see that people that have BPD oftentimes engage in self harming and suicidal behaviors, which may obviously have a strong and negative impact on their longevity, should they succeed in carrying out that behavior. The impacts of BPD are not limited to the person with the mental illness. Due to the prominent interpersonal relational difficulties that we have seen, as we saw in Mary's case, in people that have this personality disorder, their carers, family members, and friends may also be negatively affected by the individual symptoms. Common impacts on carers, family members, and friends include conflicted relationships with their loved one, emotional distress, guilt, grief, worry, and exhaustion due to the consistent conflicts that come in interpersonal relationships. Feeling like one needs to walk on eggshells around their loved one all the time so as not to trigger an argument. Stress and strains on the family dynamics, having to deal with unusual or dangerous behavior, the impulsive behaviors that were referred to in the section regarding what BPD looks like. Financial issues as a result of a reduced, unstable income or excessive spending, which again, the excessive spending could fall within the category of impulsive behaviors, but also reduced capacity to bring in money or finances could be as a result of the impairments caused by BPD and the lack of ability to maintain a job, for example. Changes in family roles, health problems as a result of stress, etc. The list goes on and on in terms of the impacts that BPD has on people in their life. The role of traumatic life experiences. Trauma is an emotional response to a distressing experience with which one cannot cope, affecting their emotions, thoughts, and behaviors. A traumatic event is one that a person finds overwhelming and often involves serious loss, threat, or harm to their well being and safety. It often results from the person's inability to cope emotionally with the situation at the time that it occurs. So, either due to lack of coping strategies, being psychologically vulnerable at the time, etc. Trauma can be caused due to a series of adverse events in childhood or adulthood, such as witnessing domestic violence, childhood abuse, parental mental illness, etc., or a single event, for example, a road traffic accident, rape, acute health crisis, etc. Essentially, trauma is when an event occurs that is threatening or harmful to a person's well-being and safety, and the person does not have the ability to cope with the situation. So all of the coping mechanisms that they have to manage challenging situations are not enough to face this traumatic event or this event. And due to the fact that they don't have those coping strategies, it then becomes a traumatic event. And it's not usually the situation itself, but the meaning that the person attributes to the situation. Data suggests that individuals with BPD are likely to have experienced childhood trauma. It is thought that this is not the event itself that impacts on a person's mental and emotional well being, but rather the way that the event is processed, perceived, and the meaning that is given to it. People who have experienced trauma in their life generally develop negative view of themselves and the world, impacting on their ability to safely navigate through life. As I mentioned earlier, when faced with a difficult or adverse event, we need to rely on our coping strategies in order to overcome the situation. If we think of children and adolescents, and data suggests that a lot of people with BPD have experienced childhood trauma, their ability to cope and their coping resources would be quite limited as they're young and they're still in the learning process. So it is not uncommon to think that if there is an adverse event such as domestic violence, abuse, any kind of abuse, witnessing someone else being abused, bullying, etc., it is understandable that children would not have the necessary coping strategies in order to face the adverse event, and therefore it becomes a traumatic life experience that they have accumulated, and many times along with others as they grow up and as they grow older. Also, for children, it is important that they have a buffer. So, an adult buffer to try and support them and help them cope with the adverse situation. When this is the case, the adult serves as a protective factor to prevent trauma from developing. However, as we know, this is not always possible. And therefore, that is another factor that influences on whether an event becomes traumatic or not. So, traumatic life experiences may impact on people in different ways based on their own experiences, their coping resources, and support networks. Some of the consequences of these experiences include the following: living in a state of hyperarousal, so being constantly vigilant of their environment and of other people, having trust issues, avoiding trauma triggers, general avoidance and withdrawal, negative view of the world and others, thinking that the world is hostile, it's unsafe. Low self esteem, so perceiving the self as weak, as incapable of being able to cope with situations. Negative thoughts and emotions, feeling numb or shut off from the world or dissociation. Sleep difficulties, anger outbursts, emotional detachment from others, disturbed brain development. A study did show that children that had been subjected to neglect would have had changes to their brain structure and size by the age of 2, whereby a child who had not experienced neglect would have presented with what we designate as a normal neurological development, whereas a child that had experienced neglect would have had a smaller brain, and there would have been multiple areas in the brain that would have been impacted due to that neglect. And that there then impacts the person further in the context of their cognitive functioning, ability to learn, ability to adapt, to adjust, etc. Difficulty planning and organizing, and risk of re-experiencing trauma later in life. How does someone's relationships throughout their life influence their personality? Attachment theory suggests that an individual requires an ongoing, intimate, and warm relationship with the caregiver in early life to have good mental health and normal social and emotional development. A good attachment relationship is characterized by a balance between support and the promotion of autonomy, to a degree where the individual's needs are met while they have an opportunity to develop relevant life skills. So essentially, it's having the child's needs met, emotional, basic needs, connection needs, social needs, mental needs, interpersonal needs, having all of those needs met, but while also supporting them in gaining skills and going into the world while still having a safe port, which would be the caregiver or caregivers. That is what we call a secure attachment style, and that is what it looks like. It is the relationship that a child develops with their parents, typically, that consists as their early attachment relationships. These relationships then serve as the foundation for how relationships work. Who are the people I can rely on to have my needs met? Where can they be found? How one needs to communicate in order to get their needs met, how others may be expected to respond when someone asks to get their needs met, how safe someone may feel in a relational context. Even though it's done in a subconscious manner, children, babies learn from a very young age through these interactions, through these intimate and warm relationships, what a relationship looks like. And then they start to use these learnings in other relationships as they grow older into childhood and adolescence. So, when we talk about relationships or early relationships with attachment figures, we have secure attachment style. So, the child has a need and cries. When they cry, the parent or the caregiver tends to the child's need, which contributes to building a trusting relationship and a safe environment. And this is done in a consistent way. What this shows is that every time that the child, the baby who cannot speak yet, has a need and they cry, their caregiver is consistent in coming to meet their need. That allows for the child to understand how it works within a relationship, how they can communicate their needs, who they can rely on to get their needs met, how they can navigate relationships in the future, how they perceive themselves in a relationship, how they perceive others in a relationship. So in this case, they perceive themselves as worthy, lovable, and other people to be trustworthy and reliable. However, in insecure attachment styles, the child may have a need and cry, just like in the first case. However, what we see is that the parent or caregiver does not tend to the child's needs or does it in a manner that is inconsistent. The child will then develop other strategies to get their needs met. In babies, we might see them start crying louder and louder and louder, or we might see babies just stop crying altogether because they realize that help is not coming on a subconscious level, of course. But the implications here is that trust does not develop between the child and their caregiver, and the child learns that they need to engage in different methods to survive. So when we think about that idea that these are the role models and this is the stage where the child learns what relationships are, how they function, how to navigate them, a child who has an insecure attachment style might perceive themselves as unworthy, as unlovable, as undesirable. They might perceive others as hostile, unreliable, untrustworthy, unsafe. And that there is going to shape the way that they view relationships, themselves, others, and the world for the future. And that is how they're going to start navigating the world based on these initial experiences that they had, which can be traumatic in themselves. Implications of having insecure attachment styles may include developing superficial relationships and connections, increased risk of developing unhealthy relationships, avoiding relationships altogether because they're unsafe, resorting to maladaptive strategies to ensure that needs are met, becoming aggressive, erratic, or angry in close relationships, having a disturbed sense of self and others due to these initial encounters with the world and others in the infancy, intense emotional experiences, delayed normative social, emotional, and cognitive development processes. How can someone know they have BPD? In the presence of signs and symptoms of BPD, which we see are in the thoughts domain, thoughts or mental domain, in the behavioral domain, emotional domain, and interpersonal domain, especially when these emerge or start to impact on daily life, seeking a formal clinical assessment by clinical psychologists and or psychiatrists is recommended in order to determine the severity of the symptoms and ascertain whether these meet criteria for personality disorder or not. It is worth noting that the engagement rate in therapy in people with BPD and personality disorders in general is poor. One of the reasons that may explain this is that in BPD, individuals are triggered by interpersonal factors. So, therapy involves the development of what we call a therapeutic relationship, and that may be in itself triggering for the individual. And that is why the engagement rates are many times poor. There are several assessment methods that can be used by mental health care professionals in the context of signs and symptoms of personality disorders. These include validated questionnaires that can be administered by the clinician, or they can be self-report questionnaires where the individual fills out their scales individually. A diagnostic interview can take place with the individuals and or their relatives and friends as well to gather collateral information which is required in the context of making a diagnostic assessment, and monitoring and record keeping of the person in the context of the different signs and symptoms of BPD. The completion of these assessment procedures aid the mental health professionals in multiple ways. They help determine the severity, frequency, intensity, and duration of BPD symptoms. They determine if the diagnostic criteria are met for BPD. They specify the level of insight that the individual has in their mental health difficulties, and this is important to determine what kind of intervention and supports are required going forward. They help develop case formulation, which is a theoretically based explanation of the difficulties, how these developed initially, and what is maintaining them. They help the clinician in conjunction with the individual to set therapeutic goals based on what the individual would like to achieve from therapy, and they help delineate an appropriate intervention plan to reduce BPD symptoms. Assessment procedures are generally administered before and after intervention so as to monitor the progress of the therapeutic intervention and to determine if further supports are required for the individual in the management of their symptoms. To summarize, in part one of this webinar, An Introduction to BPD, we talked about the role of childhood adolescent experiences, including trauma and attachment difficulties, that have been found to strongly impact on the development of maladaptive responses resulting from cognitive, emotional, and interpersonal difficulties. You should now have a greater understanding of what do we mean when we talk about personality, what it looks like to have a personality disorder, what BPD looks like, how having BPD impacts on a person's life and those they care for, the role of traumatic life experiences, how someone's relationships throughout their life influence their personality, and how to know if someone has BPD. Next, we will discuss in part two, an introduction to BPD, how can you help? So join me in part two next. Thank you for your time and attention during today's webinar. We hope you found it helpful. Should you wish to add structure to your caregiver routine, please refer to sample tools and third-party resources associated with this webinar, which have been conveniently uploaded to your learner area of the learning management system. Please keep in mind that these are only samples, and with your newly acquired knowledge, you may choose to use these in whole or in part, or research alternative resources and tools yourself. If you have any questions in relation to any of the topics or areas raised during today's webinar, please feel free to contact our team by emailing clinicaldepartment@nuahealthcare.ie. Thank you.